Hello and welcome to another episode of Onc Now, our oncology podcast series. I'm your host, Dr. Jonathan Sackier, and in this series, I have the pleasure of speaking with some of the leading experts in the field, and today's no exception. I'm thrilled to be joined by Dr. Bradley Monk. Dr. Monk is a leading gynecologic oncologist with over 3 decades of experience in clinical care and research. He completed his medical training at the University of Arizona and University of California at Los Angeles, UCLA, followed by a fellowship at UC Irvine. He's held major academic and leadership roles across institutions, including UC Irvine, as well as Creighton University and Honor Health. He's now based in Palm Beach, Florida, and he's the medical director of late-phase clinical research of Florida Cancer Specialists. Dr. Monk has led groundbreaking trials in ovarian and cervical cancer, contributing to global medical approvals. Dr. Monk, it's a pleasure to have you on the podcast. So let's dive right in. So, Dr. Bradley Monk, lovely to chat with you.
My pleasure. Good seeing you. Thank you for having me today.
You're most welcome. So this is going to be a two-parter. Let's start with part one, and let's start with some short-form questions. Just a way of getting to know you a wee bit better. So one, an interesting medical fact that you learned recently.
An interesting medical fact. Well, I'm going to focus on what I do. I work in the gynecologic cancer space every day. And you have developed chemotherapy in gynecologic cancer. That's neither new nor interesting. The next platform was anti-angiogenics, and I have published bevacizumab and other anti-angiogenics several times, even in the New England Journal.
Yep.
Nothing new, nothing. And then we went to PARP inhibitors.
Yeah.
Oh, and then ultimately we went to antibody drug conjugates.
Yep.
And now we can modulate the glucocorticoid axis through glucocorticoid receptor antagonists. And on March 31st, we showed that for the third time now, we can actually intervene in platinum-resistant recurrent ovarian cancer with relacorilant, a glucocorticoid receptor antagonist, different than an anti-angiogenic, different than an antibody drug conjugate, and that ultimately is the aha moment of the month.
It's a pretty damn good aha moment. So huge advances in your field, certainly during my professional lifetime. Tell me, what would you tell your patients is one habit that you believe is crucial for maintaining good health?
The only thing that you can change is your mind. Okay? You can't change your circumstance, but you can change your mind, and the body follows the mind. So that's the first place to start. So I tell my patients, and I tell you and me every day, let's win the day by changing your mind.
Well, you sure as hell don't change behaviors unless you change beliefs. So I'm with you there.
That's it.
Positive manifestation. So this can have nothing to do with medicine. This can be other aspects of your life, Bradley. What's the most adventurous thing you've ever done?
I'm a pretty conservative guy, and I'm risk adverse, and I hate conflict, but I do enjoy competition. And we have this sport in the United States. It's called the NFL football. It's not the football that you guys play in Europe. And so I follow that every day. And this week is the NFL draft. The worst NFL teams, they pick first from college, and the best, okay, they pick last. And so the draft is this week. So I love NFL football. Well, but I would never play it because it's violent. But that's why it's fun to watch.
Violent. I spent half my life in the United States, and I must confess, never understood football. Never understood it, and certainly didn't understand how democratized it is. It's not survival of the fittest, and in fact, in some ways, that most American of sports is the least American in the way it's organized.
That's right.
So there
well, we should have a pint. If we have a pint together after the first one, you'd understand NFL football.
I would enjoy that very much, brother.
Yep.
So great answers. Now let's dive in depth, some questions exploring your career, research, and some takeaways from the 26th Annual Congress of the European Society of Gynaecological Oncology, ESGO. I love these abbreviations. That saves my tongue from tripping over them. So, looking back from over your career, from your early days in fellowship to now leading late phase research, what would you say have been the most pivotal moments that defined your path?
Yeah, so the better part of my adult career has been trying to bring systemic therapies to women battling cancer. I'm a surgeon too. In fact, gynecologic oncology, as you know, is the only specialty that specializes in cancer, the only one. Medical oncologists specialize in medications. Radiation oncologists specialize in radiation. Gynecologic oncologists specialize in cancer. Okay. So I have worked on two things. I work on several others, but number one is cervical cancer. When I was a younger man, I was told that systemic therapy doesn't work in cervical cancer, and that's certainly not true. And I won't relive that history. And then ultimately in ovarian cancer, chemotherapy works, but patients recur. Okay. And so the intention is to do maintenance. And yes, it's treatment, maintenance treatment. So you finish your chemotherapy, you take an anti-angiogenic bevacizumab, or you take a poly-ADP ribose polymerase inhibitor, a PARP inhibitor, a pill, or both, and you stay in remission. And we can double the time that a patient is in remission simply with a pill. Okay. And so that the niraparib is an example. So those are the two, changing the landscape around the world in cervical cancer and keeping women who are battling ovarian cancer in remission so that they can live longer and live better.
Yeah. And of course, in cervical cancer, certainly during my professional lifetime, we've seen the etiology defined, a test developed, and a vaccine developed. Huge, huge, huge impact, and bless you guys for that. So, talking about ESGO 2025, was there a particular abstract or session that piqued your interest? And if so, why?
Yeah, so thank you. So we held the 26th European Congress of Gynecologic Oncology in Rome, Italy, February 20th to the 23rd. And we have several gynecologic oncology focused meetings. We have a European society. We have a Society of Gynecologic Oncology, more American. We even have an International Gynecologic Cancer Society. And the paper that was number one in impact, not easy necessarily to interpret, was a study that we collaborated on. I'm obviously in the US, and I'm the director and vice president of the GOG. And the GOG, not the Gynecologic Oncology Group, this is the GOG, is what we call it. We do randomized phase 3 pivotal trials, okay? And we collaborate with our European colleagues. And the European network is called ENGOT, the European Network of Gynecologic Oncology Trials. And so GOG 3036, ENGOT OV43, sponsored by a pharmaceutical company. They call it Keylink 001. So it has three names: ENGOT OV43, GOG 3036, and Keylink 001. And the purpose here, go back to my thesis, is to take women with ovarian cancer and to keep them in remission longer so that they can live better. And we talked about anti-angiogenics, and we talked about PARP inhibitors. And I did not mention, except in cervical cancer, the value and the impact that immunotherapy has had. Immunotherapy has changed the landscape in cervical cancer with chemotherapy and radiation, and ultimately at the time of first recurrence. What's the role of immunotherapy and maintenance treatment in advanced ovarian cancer? And this trial, which I'm going to now call Keylink, answered that question, or at least attempted to. And it was a positive study, so we can discuss that to whatever granularity you want. But Keylink was the presentation, the disclosure, if you will, that had a big impact.
Okay. Well, thank you for that. I love it when trials have really catchy names, right? So you can remember them. This enterprise seems not to have had, and it has three non-catchy names, but there you go.
Keylink.
Keylink. We'll go with Keylink. For clinicians who couldn't attend the meeting, other than Keylink, what would you say are the three top messages or findings from ESGO 2025 that you would want them to know?
Yeah. So in all specialties, we have what are called late adopters. It doesn't mean that they're slow, but they adopt things later because they're more conservative. We also have earlier adopters, and it doesn't mean that they take risks. So basically, all of the other trials and all of the other disclosures there were to add confidence to established concepts. And we had 6 FDA approvals last year in 2024. And let me sort of review sort of what those reinforcements were. And number one, I already talked about immunotherapy in cervical cancer. And so there was an update on the use and the addition of immunotherapy to chemotherapy and radiation in locally advanced cervical cancer, okay, in a randomized phase 3 trial published in Lancet. And there was more mature data and now clarity on the NCCN guidelines that immunotherapy can be used with unresectable, locally advanced cervical cancer with chemotherapy and radiation, again, with a survival advantage. That's number one. Number two, also IO in endometrial cancer. So the approvals also in 2026 expanded the footprint in advanced or recurrent endometrial cancer with IO beyond mismatch repair, MSI, DMMR, endometrial cancer. So we knew that they worked in the highest biomarker-informed population, but that's only about 75% of the patients. So there is also a benefit in mismatch repair proficient or non-MSI, and those approvals came. So we try to reinforce that basically all patients with advanced or recurrent endometrial cancer, and there are 3 immune therapies there, which can ultimately impact patients' lives. FDA approved and being adopted all over the world. Again, IO in endometrial cancer in the all-comer population, okay? And then to expand on that is adding PARP inhibitor. Now combinations, right? That's what we do. We get approvals in late line, we go to earlier line, we do combinations, and then we do other tumor types. So if you follow the life cycle here, I talked about single agents, IO with cervical cancer and radiation, IO with chemotherapy in endometrial cancer, and now the third concept reinforced at ESGO is the utilization of PARP inhibitors plus a combinational approach, adding olaparib to durvalumab. So we're still unpacking that, what that means, what the right population is. As you know, PARP inhibitors have molecular signatures that inform those outcomes. And again, I haven't mentioned IO and ovarian cancer, but that was the number one disclosure at ESGO was IO and ovarian. But the other reinforcement, big messages were IO and cervical cancer with chemotherapy and radiation, IO and all comers with endometrial cancer, and then a combination of IO and endometrial cancer with PARP.
Okay. Well, all we would say to the people who did miss the conference is don't miss the next one, because this is obviously a very intense meeting, a lot of movement. At that meeting, the ESGO-ESTRO-ESP guidelines were updated to incorporate the 2023 FIGO staging system for endometrial cancer, as I understand. Can you discuss how those updates influence clinical decision-making, patient management outcomes?
Yeah, thank you for that. So biomarkers are essential in almost every setting. Biomarkers serve 2 purposes. One, prognosis, how the patient's going to do overall, and then predictive, how the biomarkers are going to inform or predict the response to systemic therapy. So we talked about endometrial cancer specifically, how DMMR or MSI was an opportunity to inform the activity of immunotherapy. The one before that, which is very rare, is pol epsilon, pol-E. But there are other biomarkers such as ERPR, such as P53, and even HER2 in endometrial cancer. And all of those, except for HER2, now are integrated into the staging. The staging system that we use in gynecologic oncology is called FIGO, F-I-G-O. It's French, but I'll say it in English. It's the Federation International Gynaecologic Oncology Staging System. And that staging system has been updated to integrate biomarkers into the stage. Again, staging is prognostic, but I told you that biomarkers can be prognostic as well as predictive. And those staging guidelines by FIGO are now being adopted by the international societies, such as the Spanish and the European Society that you outlined. So what does that mean? That means that you should stage your patient, and you should stage your patient with the most up-to-date staging system. And I think we all do that routinely, except for POLE, because POLE is next-gen sequencing. POLE is not readily available, and it is at the top of the pyramid. But when it comes to MSI or mismatch repair deficient or ERPR or P53 or even HER2, all of that can be done at the point of care using immunohistochemistry. So again, that's what we do. We do science, we change the staging, and then we integrate it into the guidelines.
Right. And how widely deployed would you say it is globally?
So remember my story about early adopters and late adopters, right?
Mhm.
So it takes time to change the world. And that basically is according to number one, science, and two, education, and then the three, action. It is becoming more and more integrated. The challenge, obviously, in all of this is value, and value translates to cost. So when I talk about POLE, which is at the top of the pyramid, that's next-gen sequencing, which can be expensive. So its adoption has been inconsistent, except for the IHC immunohistochemistry protein assessments of DMMR, ERPR, P53, and HER2.
Okay. Yeah, I remember many years ago, I was involved in an initiative. I won't go into great detail. It was in a surgical activity in a commonly performed procedure, and there was extremely good data to suggest that everyone should do it, yet very few did.
Yeah.
And in a meeting at the American College of Surgeons, one gentleman said, stop hitting me with evidence-based medicine. I have my experience to guide my decisions. I thought that was priceless.
Yeah, I hear you.
I thank you very much for this fascinating first part of our discussion. We're going to take a wee break, and then we will rejoin and have part two.
Thank you. Good being with you today.
Thank you for listening to part one of this podcast with Dr. Bradley Monk. Please keep your eyes open for part two, where we discuss advances in gynecologic oncology and his key takeaways from the Society of Gynaecologic Oncology 2025 annual meeting. If you've enjoyed this episode, please consider subscribing on Spotify or Apple Podcasts so that you never miss an episode. Like us, leave a review, tell your colleagues, you know the drill. And also check out our archives, there's lots of great episodes. Until then, I'm Dr. Jonathan Sackier, and I thank you for listening to Onc Now. Please, everyone, stay safe, stay well, stay curious. Bye for now.